Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the South West Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a Haemareg.
And let's get started on today's topic.
From basics
to brilliance. Okay, hi David, how are you?
I'm good, thank you. Nice to see you again.
Yeah, nice to see you as well. Today we're doing one of my favourite topics, mantle cell lymphoma, for which Plymouth is famous for this topic. So it's very.
We have to do it justice, don't we? Otherwise,
exactly.
people will talk.
Rock Raw will be after us. Yeah.
Yeah, that's the one.
So, do you know? Let's just start from the beginning. What do you know about mantle cell lymphoma?
So I know it's a lymphoma.
Yeah.
And I know that the mantle zone bit refers to part of the lymph node.
Okay.
And I know it has a quite classical sort of genetic translocation.
Yeah.
And not a lot else, if I'm completely honest. It's not that common, is it? So yeah.
Yeah, good. So I mean, yes, you're right. It's rare. It's more of a disease of men. I think it's a ratio of about 3-1 men to women. So more of a male disease. And it is a type of lymphoma, which I would say has the worst features of both low and high grade lymphoma. So classically, what do we say about low versus high grade lymphoma? Do you know?
So high grade lymphomas tend to be pretty nasty, but pretty treatable. Yeah. So you can do things about them with chemotherapy. And the low grade lymphomas don't tend to sort of cause the hideous scares that we sort of get bleeped for, but they tend to be very hard to eradicate.
Exactly. So low-grade lymphoma, not very curable. High-grade lymphoma can be quite instantly life-threatening and need treatment quickly. And unfortunately, mantle cell kind of has both of those features often. So it's not curable by conventional chemotherapy. And so by today's standard, it's often not curable. And as you correctly said, its name mantle cell comes from that part of the lymph node. So you've got the germinal center right in the middle of the lymph node, where you've got things like your follicular lymphoma coming from. You've got your marginal zone, which is the outermost part of the lymph node, which is where you get things like your marginal zone lymphoma. And then you've got your mantle zone, which is that bit in the middle around the outside of the germinal center where you get your mantle cell lymphoma. And do you know, you said that there was a classical genetic translocation. Do you know what that is in mantle cell?
So yeah, I've heard of the T1114 translocation, which I think is the cyclin D1, one of those that sort of pushes things through that replicating cycle.
Yeah, absolutely. So chromosome, it's T1114, so chromosome 11 contains cyclin D1 gene, and I remember it as the 11 being like 2 1s and then D1 cyclin D1. And then chromosome 14 is your immunoglobulin IgH gene. And what happens is your cyclin D1 gene comes under the control of the promoter of the IgH and so becomes overexpressed. And so you get increased levels of cyclin D1, which, do you know what the role of cyclin D1 is normally?
Yes, so it's part of the cell cycle replication, isn't it? So the build-up of cyclin D1 then pushes it into mitosis, and there's a few checkpoints in there as well that should stop things.
Exactly. It's one of the sort of checkpoint parts of the cell cycle at the G1S phase boundary, and it basically will translocate into the nucleus and act via the retinoblastoma protein. It will kind of get rid of the repressive action of E2F, which is an important transcription factor. And so it therefore kind of unleashes the cell to proliferate. and so that's and produce this unchecked cellular growth. So we do think that the T1114 and that overexpression of cyclin D1 is the pathogenesis behind mantle cell lymphoma. The other thing that is upregulated and overexpressed classically in mantle cell is this thing called SOX11. And SOX11 is basically a transcription factor mainly found in neural cells, weirdly. But that is also a classic sort of overexpression seen on immunohistochemistry, for example. And it's really useful to have both that translocation T1114 and the SOX11 being overexpressed, because you can test for both of those, and that will help to confirm your diagnosis along with other immunohistochemistry. So yeah, so that's the pathogenesis. So what's the classical presenting complaint in mantle cell lymphoma?
So I've met many people with mantle cell lymphoma, but I'm going to go out on a limb and say it's something to do with, I guess, nodes, whether people either feel them from a sort of superficial point of view, or they have a scan and someone goes, gosh, what is this large mass in the middle of your chest or your spleen or something like that?
Yeah, so you're partly correct. Classical mantle cell lymphoma does present with nodal disease, and you can get a lot of lymph nodes. But the large lump in the chest that you just said, I would say that actually classically mantle cell lymphoma doesn't have either bulky disease or B symptoms. So if you had a big area of bulk, it wouldn't necessarily make me think about mantle cell lymphoma as one of the differentials initially in my head. I mean, obviously it's a possibility, but classically they don't get bulky disease and they don't get much in the way of B symptoms. What they do get a lot of is nodal disease and a lot of extranodal disease, particularly at presentation, and in particular involving the liver and the GI tract. So there's this kind of preponderance to those two areas that are involved, but other areas can be the spleen, the bone marrow, in which about 50 to 90% of cases have involvement of the bone marrow at presentation. You can also get leukemia with mantle cell. So mantle cells in the blood. And then also you can get things like breast, lung, skin, soft tissue, salivary gland, and orbit involvement as well. Median age of presentation is 68 years old, so sort of middle-aged to slightly older. And as I said before, it's a male predominant disease of a 3-to-1 ratio. So it's quite common for patients with mantle cell to have more than one extranodal site as well. So up to 50% of patients have more than 2 extranodal sites involved at presentation. So it's quite advanced stage. And over 90% of patients will present with stage 3 or 4 disease. So that's quite different to, a lot of your patients with DLBCL that you might have seen, where they just present with a single node, stage 1 disease sometimes. Over 90% of patients with mantle cell will have stage 3 or 4 disease at diagnosis. So I think that's interesting to note. It's quite different.
Yeah, I guess that's it, isn't it? You sort of assume that a lymphoma comes with bulky disease that you can point at and go, there it is. But it sounds like by the time these people actually present, they've got pretty diffuse spread disease.
Yeah, absolutely.
I did notice you said classical a few times, classical mantle cell lymphoma. Does that mean that there are different ways to classify?
Yeah, absolutely. The WHO loves to classify our malignant hematology conditions. So in the most recent edition in 2022, they divided mantle cell into 3 different kinds. So the first kind is what I refer to as classical mantle cell, although it's not technically called that. It's called cyclin D1 positive mantle cell lymphoma subtype. And
I like classical. I think we should partition them to endorse it.
Yeah. Put out a petition for it. But basically what everyone calls classical mantle cell lymphoma. So it's cyclin D1 positive, so it's your classical T1114 translocation, and greater than 95% of cases of mantle cell have this T1114 translocation, and that leads to the upregulation of the cyclin D1. Occasionally, the cyclin D1 can translate with a different partner gene like IgK or IgL, but it's usually IgH. But as long as they've got upregulation of their cyclin D1, then that's your cyclin D1 positive mantle cell lymphoma. Then you have your cyclin D1 negative mantle cell lymphoma subtype. Now, this is quite unusual in that they don't have upregulation of cyclin D1. Although actually instead they often have upregulation of a similar cell cycle checkpoint. So cyclin D2, cyclin D3, or cyclin E rearrangements have often been found, which lead to cell cycle dysregulation. And it's really rare. And so it's always a bit unnerving when you think someone's got mantle cell based on other investigations you've done, like the immunohistochemistry pattern, for example, or maybe the SOX11 being upregulated, but the cyclin D1 not being overexpressed. And so you should often then go on to look for the cyclin D2 or D3 upregulation instead. And then the third kind, which is the other sort of clinically significant kind, where you may well encounter it, and I've met patients with this, is the non-nodal mantle cell lymphoma. And non-nodal mantle cell lymphoma, they have little or no lymphadenopathy, as kind of hinted by the name, and they have minimal symptoms often and generally have a better clinical outcome. And so what they typically have is leukemia, so blood involvement, and they'll often present with a lymphocytosis, bone marrow involvement, and involvement of the spleen. Okay. And they will often not have an overexpression of SOX11. They'll often have a low proliferation index compared to normal mantle cell, and they'll often lack CD5 expression as well. So there are such things as aggressive non-nodal mantle cell lymphoma, but generally it's quite an indolent condition. And when I think about the patient that I've met with non-nodal mantle cell lymphoma, she just had a bit of a lymphocytosis and she actually never needed treatment. And she died of something else in the end. And so it's definitely the good one to have in general. So you've got cyclin D1 positive, cyclin D1 negative, and then non-nodal mantle cell lymphoma, which is quite different to the more sort of classical mantle cell lymphoma.
Okay. It feels quite hard to jump to mantle cell lymphoma as a differential diagnosis. What would make you think, this person's got lymphocytosis? What would make you think, is this MCL?
Yeah, that's a really good question. And I think things that would make me, anything that looks like it might be a new lymphoma obviously could be mantle cell lymphoma. But clues would be if you had a CT scan with lots of extranodal disease, for example, or lots of nodal disease, but quite small, not bulky, and patients not having lots in the way of B symptoms, then that might make you think about mantle cell lymphoma. Particularly if they're then male and they're sort of, around the age of 68, the median age. But then in terms of lymphocytosis, that's another way that patients can present, query CLL, for example. And that's where a blood film can be really helpful and to look at the lymphocytes that you're seeing in the blood. So obviously with CLL, we've talked about the appearance of the lymphocytes often looking like small, mature lymphocytes with a round nucleus with quite dense chromatin. In mantle cell lymphoma, you have a cleaved nucleus. And I like to think of it as like a fish mouth. So it has like a bit of an indent into the nucleus, which looks like a little mouth of a fish or like a mouth of a Pac-Man. So it's quite an open kind of groove, and it doesn't go very deep into the nucleus, which I'm describing in a lot of detail because that's in contrast to follicular lymphoma, which is your other big differential for cleaved or clefted nuclei of lymphocytes in the blood. And in follicular lymphoma, the cleft tends to go much deeper and kind of make it into two separate like lumps as part of the nucleus, and looks less like a fish mouth, basically. And so that's kind of your characteristic appearances on a blood film that would make you think about mantle cell more than follicular or CLL, for example. And then obviously most of the time, I guess most of the way in which mantle cell is diagnosed is just on the basis of a lymph node biopsy. And so that's just going to be a key investigation, of which then the immunohistochemistry and the translocation and the expression of SOX11 and cyclin D1 give you the diagnosis of it being mantle cell lymphoma.
Got it. So shallow Pac-Man. That's what I'm going to take away.
Yes.
Shallow Pac-Man and deep Pac-Man. Will that'll go into my brain.
Yeah, perfect. So what investigations, just starting from the beginning, if you had somebody that you thought might have mantle cell, let's say you've looked at a blood film, they've got the kind of Pac-Man fish mouth nucleus of the lymphocytes in the blood, what investigations, starting from your clinical assessment, would you do for somebody that you thought might have mantle cell?
Okay. So you said earlier about it sort of affecting the GI tract particularly.
Yes. Yeah.
So I guess for any symptoms that may arise from a GI tract, whether that's sort of bleeding, or whether they're having sort of diarrhea, it's something odd, something off from a GI tract point of view, I think would sort of push me in that sort of direction.
Yeah.
You said they didn't particularly have B symptoms, but also I guess if we're talking about, a person in the right demographics with sort of something weird going on, a lymphocytosis with some GI bleeding, maybe that would push me down that line.
Yeah.
And then I guess standard things like full blood count.
Yeah.
And then get that peripheral film going so that you could see what the cells look like.
Yeah.
And then I'm sure there are lots of clever flow things and clusters of differentiation which will particularly drag out mantle cells as opposed to follicular. Yeah. And then if we've got a nice translocation to look for, I suppose some kind of fish.
Yeah, excellent. Yeah, that's really good, David. So I agree with your clinical assessment, a GI bleeding history in particular, because more than 90% of mantle cell lymphoma patients have at least microscopic mantle cell in their GI tract, which I think is really interesting. They don't all get any symptoms from it. So it's just about screening for those that do, because that may well be an indication to further investigate the GI tract. B symptoms, and then examining them for hepatosplenomegaly and lymphadenopathy, including Walde's ring, so looking in the back of the mouth and looking for any, tonsillar tissue there that's enlarged, considering that we know that they get GI tract and liver involvement in particular, and lots of extranodal disease, looking at their skin when you examine them for any evidence there, and then, as you say, full blood count and a blood film, and then because if they do have lymphocytes on their full blood count and their film, then making sure that we then do peripheral blood flow. And the markers for that are CD19 and CD20, so your classic B cell markers, and then FMC7 positivity, which I remember is flipping mantle cell.
Nice.
FC7, you just have to remember the 7. And then CD5 positive, and then CD10 negative, CD23 negative, and CD200 negative, in which the CD23 and CD200 negativity help you distinguish it from CLL on flow. And then you can also do FISH on the peripheral blood, as you say, for the translocation 11-14, if they've got leukemia, if they've got lymphocytes in the blood. And then you're going to do your basic biochemistry, including your urate, your LDH, and your LFTs, because you do get quite a lot of tumor lysis with mantle cell. You're going to do your standard viral serology like you do with all malignant conditions, hepatitis B, C, and HIV. And then if you haven't got a diagnosis based on peripheral blood involvement, then you're going to need to get a biopsy. And we always suggest excision over core biopsy, but core biopsy is obviously better than an aspirate. And you're going to do immunohistochemistry for your cyclin D1 to look for that being upregulated, your SOX11 to see that that's overexpressed, and then also BCL2, which is going to be positive, and BCL6, which is going to be negative. And then you can do your FISH for your 11-14 translocation. And then one other thing that's really important, and we met this before in CLL, is doing a TP53 mutation analysis. And you should do that in all patients at diagnosis, because it's an important prognostic marker and might inform, how you treat that patient. And then I would just say, remember, if they're a younger patient, think about fertility counselling or preservation where it's appropriate. And then if they're an older patient, because, median age is 68, so you're going to get patients that are going to be at the older end of that spectrum, then a formal frailty assessment. So we know that frail patients have poor outcomes with intensive chemotherapy with mantle cell, and it might make you want to treat them in a different way. So you can do like the geriatric 8 screening tool or the cumulative illness rating scale. and maybe involve a geriatrician to get really good functional baseline of the patient. And the most recent BSH guidelines on mantle cell in particular promote the use of proper documented frailty assessments using one of these scores rather than just an end of the bedogram. So those would be your investigations. Great. Okay, so next we also need to stage the patient with mantle cell lymphoma. Any ideas what would be the best way to stage somebody with mantle, David?
So I'm guessing a PET scan. That seems to be our go-to for most things. I don't know why you would do a PET over a CT, but I'm going with PET scan.
Yeah, you're right. Much higher accuracy of staging than a CT in about 20% of patients. It's just basically better we know that PET scans in lymphoma are better generally at detecting sort of nodal and non-nodal disease in particular. Remember when we've met PET scan in previous lymphomas, it's been good at upstaging patients, particularly for the extranodal disease, which is harder to pick up on a plain CT. So PET scans in mantle cell are really good at picking up nodal disease and splenic involvement. The SUV, the higher it is, the more aggressive the variant of mantle cell, which can be useful. So they correlate. And also it has prognostic significance using PET throughout, because if you do an end of treatment PET scan and you have a complete metabolic remission rather than just a standard, radiological remission on a CT, then that is actually it's associated with an improved overall survival. So that's another pretty useful reason to use a PET scan over a CT scan. The only thing I would say about PET, though, is that it's not very good at extranodal disease, in particular on picking up bone marrow disease in mantle cell and GI disease in mantle cell, which is a bit unfortunate because we've actually said that those are two areas that are often involved in mantle cell. So there was a meta-analysis which showed that PET was 36% sensitive to bone marrow disease, and that it's 39% sensitive to GI disease. And that's comparing it to a bone marrow biopsy and comparing it with endoscopy and a biopsy. And in particular, it's bad at picking up colorectal disease it's particularly bad at picking up gastric disease compared to colorectal disease. So it's better at picking up colon involvement, but it's not very good at picking up stomach involvement. So what do you think we do to stage those patients further? What else do you think we might need to do as well as a PET?
So I guess if you're not good at seeing bones, then I guess you put a large needle in one and find out what's inside them.
Yeah, absolutely.
And if you're not good at seeing GI tracts, you get a camera and have a look down.
Yeah, exactly. So bone marrow biopsy, the BSH recommend that you should routinely do that as part of your staging for patients with mantle cell, given how commonly the bone is involved and how poor a PET scan is at detecting bone marrow involvement. So we would routinely do a bone marrow biopsy as part of your PET plus bone marrow staging. In terms of endoscopy, don't necessarily need to do a colonoscopy because we think that a PET scan probably would pick that up unless there were symptoms of bleeding or something that you were worried about. But an OGD is something that you would consider doing. You would only do an OGD, though, if you had symptomatic disease, okay? Because we know a lot of patients have microscopic involvement of their bowel, but they don't necessarily ever have any symptoms. Or if you had a patient that you thought had stage 1 disease and you were going for radical radiotherapy treatment and you really wanted to make sure there was no disease anywhere else before you did that, then that would be the other situation in which you would need to do an OGD. So symptomatic disease, for example, upper GI bleeds, or confirmation of it being an early stage, then you should also do an OGD. And then finally, if they had symptoms of anything neurological like headaches or signs on examination, then you would do an MRI scan and a lumbar puncture for CSF morphology and flow. But it's quite uncommon to have CNS involvement at diagnosis, despite being quite late stage disease at diagnosis. It doesn't tend to affect the brain. So you would only do that if you had suspicion of it on your clinical assessment. Okay.
Understood. Yeah. So that's our investigations.
Yeah.
From what you're telling me, generally speaking, MCL doesn't have great outcomes. What I guess key features identify someone who prognostically is going to do well and those who are going to prognostically do less well?
Yeah. So firstly, just thinking about what's the likely subtype of mantle cell that you're dealing with. So is it the kind of classical mantle cell, so the cyclin D1 positive mantle cell with the upregulated SOX11 expression? Or is it your non-nodal mantle cell lymphoma? Have they just got blood, bone marrow, and spleen involvement? In which case you can expect with those non-nodal patients to have a bit of a better prognosis and more of an indolent condition. But then in terms of your classical or your cyclin D1 positive mantle cell lymphoma, there are a couple of biomarkers. And one is cytomorphology. So how do the mantle cells look under the microscope on the biopsy or on the blood film? You've got, in particular, your blastoid appearance, so where they've got big nucleoli and they just look quite aggressive. They have a poorer prognosis, as do your pleomorphic ones. The second thing is Ki67. Do you know what the Ki67 is?
It's a proliferation thing, isn't it? The higher the number, the higher the grade of the lymphoma.
Yeah, exactly. So it's your proliferative index, and this is actually the most important prognostic factor in mantle cell lymphoma at the moment, is how high your Ki67 proliferative index is, which is interesting because obviously it gives you a degree of and a feel for how high grade a lymphoma is in other types of lymphoma, but it's not as prognostic as it is in mantle cell. So particularly if you have a Ki67 above 30%, so we're not talking really high, certainly not talking anywhere near Burkitt's kind of level, but anything over 30% correlates with a poor outcome. Bear in mind, however, that although it's a really useful and very predictive prognostic factor, it can be quite subjective and quite non-reproducible. So just bear that in mind because it is done based on someone eyeballing the biopsy and estimating how much they think that biopsy stains for Ki67. And then the other really important thing is the TP53 mutation, which we talked about earlier in our workup of somebody we think might have mantle cell lymphoma. And obviously, if you're TP53 mutated, then you've got poorer outcomes. Interestingly, deletions are not the same. So we think that's because if you have a mutation in TP53 in mantle cell lymphoma, generally you get a biallelic disruption of TP53, so both alleles are affected. As if you have a deletion of your TP53, that can be picked up as a deletion, but it's often only a deletion on one of the chromosomes. And so you've still got one that works. And actually, therefore, TP53 deletions aren't associated so much with poor risk disease compared to mutations. Okay. And then all of your patients at baseline with mantle cell should then be risk stratified using what's called the MIPI, which stands for the Mantle Cell International Prognostic Index. And this uses age, performance status, white blood cell count, and LDH, which is why it's important to do that on your biochemistry at the beginning. And it predicts overall survival and progression-free survival at the time of first-line treatment in mantle cell lymphoma. And it was based on the research from the Mantle Cell Lymphoma 2 trial. And so we do a MIPI. A low-risk MIPI score gives you an overall survival of about 9 years. A high-risk MIPI score gives you an overall survival of about 2 years. So quite a big range. Overall, that's not a great overall survival for either of them, even the low-risk MIPI patients. So I think that's worth noting. And so if I'm telling somebody in clinic that they have a diagnosis of mantle cell lymphoma and they ask the kind of classic question of, how long would they be expected to live with this condition? Probably we're looking at years, basically, would be an accurate way to describe it, up to sort of 9 or 10 years, down to as low as sort of more around 2 to 3 years if you've got a high risk MIPI. And then they have also improved the MIPI, so they've gone on to do the MIPI B, which is MIPI B for biological, which includes the Ki-67, as does the MIPI C, which also includes the Ki-67 percentage. But yeah, so those are the different prognostic scores, which can be really helpful to give a rough idea of overall survival for patients. So let's take an example patient now, David, and see what you might think about it. So we've got a patient with lymphocytes of 10. They go on to have peripheral blood flow because someone thinks they probably have CLL, and they are CD19 positive, CD20 positive, FMC7 positive, but they are CD5 negative, CD200 positive, and CD23 negative. So not typical mantle cell, CD5 negative note. Peripheral blood FISH, however, shows a T1114 translocation. They have a PET scan, which shows splenic involvement but no lymph nodes. They have a bone marrow biopsy, which shows that they do have bone marrow involvement with a Ki-67 of about 10%, and SOX11 is not upregulated. And their TP53 status is unmutated. How would you manage that, David? What do you think about this case?
I think the thing that stands out to me to start with is that it doesn't sound all that, I guess, classical in the worrying sense. It doesn't quite have the right markers.
Yep.
And the Ki-67 is pretty low.
Yeah.
And the SOX11 isn't that upregulated.
Yeah.
And we've got an unmutated or wild type TP53.
Yeah.
So that sounds to me like good news within the context of a mantle cell. Absolutely. So we've done this a few times now, and usually the first answer is to do nothing. Yes. And usually I want to do something, and you ring the alarm bells about me falling into your trap. So I'm going to say I think this is a watchful waiting type scenario.
Yes, exactly. Yeah, exactly, David, because this is a non-nodal mantle cell lymphoma. It's a classical case, okay? And so with non-nodal mantle cell lymphoma, it's often going to be indolent. And 10 to 15% of all mantle cell lymphoma will take a very indolent course, especially this non-nodal mantle cell lymphoma. You've got bone marrow involvement, you've got peripheral blood, and you've got spleen involvement, but your SOX11 isn't particularly upregulated, and you've got not any nodal involvement on PET scan. You've got a low Ki-67, which is reassuring, and there's nothing blastoid or pleomorphic on the histology as well. So well-selected non-nodal mantle cell lymphoma, i.e. reassuring results like this, can just be initially safely observed. And there was a UK mantle cell lymphoma biobank observational study, which was published in Blood in 2019, which showed that at 1 year of observation only, 75% of patients continued on a watch and wait, and greater than 50% of patients at 2 years from diagnosis were still on a watch and wait. So watch and wait is a perfectly appropriate thing to do here, because there's no evidence that early treatment of these patients would have any effect on their overall outcome. If they had things like a raised LDH or a high Ki-67 over 30%, then they might be more likely to require treatment sooner. But this patient, you wouldn't need to treat, unless obviously I'd missed something out about the history. Maybe they had GI bleeding or something from GI involvement. The other thing you could consider is if there was any trials with early intervention trials using non-toxic therapies, which we can talk about later. But generally, watch and wait would be perfectly appropriate for this patient. Okay, good. So what about a different patient? This time presents with a single lymph node, which has been biopsied, and has been found to have the translocation 11-14 and also has upregulation of SOX11. They have no GI symptoms. They've got a normal full blood count. What else would you do in this situation, and how would you treat them?
So I think this is PET time.
Yeah.
So I want to scan to see if there is any other extranodal or distal nodal disease.
Yeah.
They don't have GI symptoms, so I'm unlikely to do an OGD.
Okay.
I probably want to do a bone marrow.
Okay. Yeah, good.
And then escalate to senior.
Okay, fine.
Yeah.
So basically, the key point about this case, David, is that it sounds like this patient could have localized stage 1 disease. So yes, get the PET scan to confirm nowhere else is involved apart from that lymph node, and get your bone marrow biopsy, as you correctly said, as part of your staging. But in this situation, I would get an OGD, even though they have no GI symptoms, because this is a patient you want to be really sure has truly localized stage 1A or stage 2 disease that can be treated by local radical radiotherapy, potentially for cure. What you don't want to do is go down the cure route of, I'm just going to zap your groin node and cure you, if they've actually got microscopic involvement of their GI tract that you haven't been able to
got you.
Okay, so that was the purpose of this case. I've obviously put it in deliberately to try and catch you out.
And I walked in dutifully. You're welcome.
Yeah, sorry. Okay, third case. So this patient has splenomegaly and enlarged lymph nodes on a PET scan with a mild anemia and a positive bone marrow biopsy. They're less than 65 years old. They've got no past medical history. What would I do in terms of treatment? Would you start treatment in this patient?
It sounds quite worrying, doesn't it? I think, we start straight away.
Yeah, good. Okay. So unless you've got an indolent subtype of mantle cell lymphoma, you would generally start treatment at diagnosis for mantle cell because it's got that crossover of features of both high and low grade disease. It's not curable, but it still has the sort of need to treat like with high grade lymphoma at diagnosis. And generally the sort of algorithm for somebody who's sort of fit for a stem cell transplant, for an autologous stem cell transplant, and this person is less than 65 and has no past medical history, would be intensive chemotherapy, particularly involving high-dose cytarabine plus rituximab, in which you typically would give 2 cycles of R high-dose cytarabine, then harvest their stem cells and then do another 2 cycles and get them into a sort of remission. Then an autologous stem cell transplant using either BEAM or BEAC, BEAC conditioning. And then after you've done the auto, putting them on maintenance rituximab. So giving them a rituximab infusion every 2 months for ideally 3 years, but the NHS funds 2 years. And so you have this weird situation in mantle cell where some patients may opt to pay privately for the 3rd year of rituximab maintenance therapy if they're able to. So expected outcomes with that treatment, generally the intensive induction and autologous stem cell transplant gives you a 4 to 5 year progression-free survival rate of about 50 to 70%. Almost no patients will be cured by having this regime. Very few patients having this treatment regime will have a progression-free survival of more than 10 years. And that would be, if you think back to your MIPI, even your low-risk MIPI, your overall survival was about 9 or 10 years. So, but this is what we would do. So choice of induction. I've said high-dose cytarabine and rituximab. There are no good randomized control trials to inform us as to what we should use for induction. There's nothing that's clearly superior, but overall response rates generally using something with cytarabine are about 90%, and CR rates are about 50%. So 50% of patients will get a complete response, which you then want to consolidate with an autologous stem cell transplant. there is a clear benefit of incorporating high-dose RSE. So the mantle cell lymphoma younger trial was a trial that compared R-CHOP versus R-CHOP alternating with RDHAP. Have you heard of RDHAP before?
No, not come across that.
Okay, so R is for rituximab, D is for dexamethasone, the HA is for high-dose RSC, and then the P is for platinum, so it's a cisplatin. And they found that alternating R-CHOP with RDHAP and adding that high-dose RSC did make a difference on overall survival. So we know that mantle cell lymphoma generally doesn't like high-dose cytarabine or high-dose RSC, okay? And actually, at my hospital, where I did my ST3 and ST4, we used to just use high-dose RSC and rituximab to avoid the toxicity of the platinum in RDHAP. And so some places will do that, but a lot of places will do R-CHOP, RDHAP alternating, which sometimes people refer to as the Nordic protocol. But anyway, those are your choices of induction: something with high-dose cytarabine and something with rituximab. Okay. And the maintenance therapy of the rituximab for 3 years not only improves progression-free survival like we've seen in things like follicular lymphoma, but it actually improves your overall survival. So there was a paper published in New England Journal of Medicine in 2017 which demonstrated this. So it's actually really important that patients do go on to have rituximab maintenance if they have mantle cell, because you're actually going to potentially improve that patient's overall survival. It's not just delaying their inevitable relapse. So that's really interesting and quite different to that of follicular lymphoma. And in terms of why we do the autologous stem cell transplant, again, it's hard to tell what the benefit of the intensive chemo induction is in the context of the fact that all those patients go on to have an auto. And so separating out the intensive induction from the auto and the benefits of each is quite hard to do. You can either use BEAM or you can use BEAC, as I said, either of those conditioning regimes. So BEAM being carmustine, etoposide, cytarabine, and melphalan, as BEAC being where the melphalan is substituted for cyclophosphamide. We tend to do BEAM autographs at our hospital, but there's no clearly established optimal conditioning regime. What we do know about doing an autologous stem cell transplant is from the mantle cell lymphoma younger trial again, which I talked about earlier. And it showed that doing an autologous stem cell transplant increased your MRD, so your minimal residual disease rates. And we know that MRD is known to correlate with improved overall survival. And so that's why we think that it is of benefit. Okay. So we recommend doing an autologous stem cell transplant for all patients who have gained at least a partial response with the induction. So you need to have been able to demonstrate that they've got chemosensitive disease. So they need to have got at least a partial response rather than just stable disease. But if they've had a partial response or better, then they would go on to an auto and then followed by that maintenance rituximab. Does that make sense?
Yeah, it sounds like there's real benefits every step going through.
Yeah, good. Okay, so that's that sort of patient. What about if we had the same patient with the lymph nodes and the splenic involvement and the bone marrow biopsy that was positive, but they had other features such as TP53 mutated and they had quite blastoid looking cells? What would you be thinking?
That sounds hideous, is what I'm thinking.
Yeah.
I'd be, and I imagine that their outcomes are very poor.
Yeah.
I don't know how management, deals with such a stacked deck against them.
Yeah, you're right, David. So you've correctly identified that these are your poor risk, high MIPI mantle cell lymphoma patients. And the mantle cell lymphoma 2 and mantle cell lymphoma 3 trials showed a progression-free survival of about 11 months for these sorts of patients.
Ouch.
So yeah, pretty dismal. So it makes you think, well, it's not, do we really want to put them through all of that for that progression-free survival. And I think in an older patient, that becomes much more of a debate about whether they even want to go down treatment route or whether they want more palliative care. So don't forget that that's always an option that needs to be really well discussed and explored with your less fit patient. But for your younger patients, there isn't really anything else unless you can get them into a trial, which you would definitely want to look for. But otherwise, in the absence of any other better treatment, we are still recommending intensive chemotherapy, so the high-dose cytarabine or Ara-C with rituximab, and then the autologous stem cell transplant, in the absence of there being any better options, basically. So, yeah, it is a bit grim. And it's one of the reasons that mantle cell lymphoma, to me, is so interesting, because this is still a condition that we are not treating very well or not able to treat very well. And so yeah, there's a lot of research still to be done. Okay, what about if we had the same patient with lymph node and splenic involvement, but this time they're not fit for an autologous stem cell transplant? Let's say they're in their late 70s and they've got some comorbidities, or they're just not got a great performance status. Do you know what we would consider for these patients?
I imagine giving something with rituximab plus the chemotherapy.
Yes.
Would that be like an R-CHOP kind of place? I don't know whether a high-dose Ara-C would, push them over the edge. But yeah, R-CHOP seems the usual answer to most things, isn't it?
Yeah, exactly. So again, there are no randomized control trials in this setting. So most people probably use R-bendamustine.
Okay.
There's probably a progression-free survival advantage to that of R-CHOP. But R-CHOP is still a reasonable option as well, as long as their comorbidities don't involve lots of cardiac toxicity, remember, because otherwise you don't really want to be giving them full-dose anthracycline. If you think they're sort of a bit borderline and a bit fitter, then RBAC, which is rituximab, bendamustine, and high-dose cytarabine. And that's pretty good. It's got a 7-year progression-free survival of above 50%, but it comes with a lot of toxicity, particularly low full blood count and infections. So that's why I say consider it in those that are borderline in age, maybe like 65 to 70, or those who are in their 60s to 65 but are not very fit. You might want to use RBAC. So yeah, those are your options really. And then what if they're extremely frail? Do you know what you would consider in that situation?
Is that sort of our CVP kind of territory?
RCVP, yes, or R-chlorambucil, yes, or you could give attenuated dose bendamustine in R-bendamustine or R-mini-CHOP. So yes, any of those. Again, there's no head-to-head trials to know what's best in this situation. Consider steroids as a pre-phase, okay? Especially where you think the disease burden is contributing to their performance status. Because remember, there's a lot of extranodal disease. So if you can shrink stuff down initially with steroids, you might actually find that they improve and then they're a bit fitter for something a bit zippier. The BSH guidelines recommend involving a geriatrician to optimize comorbidities. And also just to note that unlike in a lot of other lymphomas where rituximab monotherapy can sometimes be useful, it's not really a thing in mantle cell lymphoma like it is in things like follicular and diffuse large B-cell lymphoma. So that's not really an option because it's just not as active in mantle cell on its own. And don't forget about palliative care and radiotherapy to kind of spot weld places, because especially if you had an older patient who's not very fit and has very poor risk disease on the MIPI, a very informed discussion about their likely progression-free survival or overall survival will be really useful for the patient to be able to make an informed decision. They might not want to go down the treatment line at all. Okay?
Yeah, got you.
Have you heard of any exciting new treatments for mantle cell lymphoma, David?
I've been waiting for this because I actually have heard of a trial, so I thought I would flex my the triangle trial.
Yes, yeah. So the triangle study, I'm glad you bring that up because that is quite an exciting UK-based study. I think it's mainly being run out of Oxford, that's been published in Blood in 2022. And the preliminary data is quite exciting. It does make it look like an autologous stem cell transplant may be a thing of the past, with the advent of the use of ibrutinib. So let me explain what I mean by this. So the triangle study was firstly run in patients that were fit enough for an auto. So we're going back to our first line treatment, autologous stem cell transplant fit patients. And there were essentially 3 arms to this trial. The first arm, patients were randomized to, were R-CHOP alternating with R-DHAP. So this was the kind of Nordic style protocol. So intensive chemotherapy, followed by an autologous stem cell transplant. So that's current standard of care in the NHS. The second arm was looking at R-CHOP/R-DHAP alternating with ibrutinib up front. Okay, so you take ibrutinib once a day, and then an autologous stem cell transplant with ibrutinib maintenance. So basically, you just keep taking ibrutinib the whole time. And then your third arm was ibrutinib up front with your R-CHOP and your R-DHAP alternating induction, followed by ibrutinib maintenance alone, so no autologous stem cell transplant. And what they found is that the autologous stem cell transplant with ibrutinib is not superior to the ibrutinib arm alone, suggesting, therefore, that you don't need to do the autologous stem cell transplant when ibrutinib is used up front with R-CHOP, R-DHAP induction, and for 2 years of maintenance, which is really interesting.
Nice.
Yeah, really, really interesting. And a really cool trial, really well-designed trial. And it may well be quite practice transforming. I was talking to some of my consultants about this the other day, and the only thing that they were saying is that although this is potentially suggests that we might stop doing autologous stem cell transplants up front in mantle cell lymphoma patients, they said that Janssen, that holds the license for ibrutinib, is not currently applying to have ibrutinib to be used in this manner. And therefore, even though the data may suggest that by using ibrutinib up front, you might be able to ditch the auto, this may not actually end up being the case because of the drug company not wanting their drug to be used in this way. And it's worth saying that ibrutinib in the US has really fallen out of favor. So obviously, ibrutinib is we talked about it in CLL before, didn't we? And it's your first generation Bruton tyrosine kinase inhibitor. And data in CLL has demonstrated an increased rate of sudden cardiac death, as well as, the toxicities we already know about hypertension, bleeding, and AF. But in particular, the sudden cardiac deaths really spooked the Americans. And so at the moment, the license is on hold for ibrutinib in the US currently, to the extent that they're even thinking, should we be taking patients that are doing well on ibrutinib for Waldenstrom's or CLL or mantle cell and swapping them to something else because they're so worried about it. So I think what the triangle study shows, though, is that there is this potential for using a non-chemo drug like ibrutinib to replace the very chemo-intensive autologous stem cell transplant, which I do think is a really interesting concept. I think that's why.
Are there sort of later generations of the BTKs that are less cardiotoxic or less side effects?
Yeah, there are the second generation ones. So things like acalabrutinib, and then also things like your non-covalent ones as well. So things like zanubrutinib, and in particular, there's a big interest now in using Bruton tyrosine kinase inhibitors, particularly in mantle cell lymphoma in your older population. So as a sort of what they call chemo-free regime. So using rituximab plus ibrutinib. So for example, there's one study called the SHINE study, which is only open to those over the age of 65. And what they did is they had patients who had R-bendamustine. So these are patients that are not fit for an autologous stem cell transplant. So they're having R-bender. And they had R-bendamustine, and then they were randomized to have ibrutinib added to R-bendamustine or a placebo added to R-bendamustine, followed by rituximab maintenance with ibrutinib continuous therapy until progression. And they showed that the addition of ibrutinib improved progression-free survival, but not overall survival at 7 years. And so I thought that was an interesting study. They had increased adverse events with ibrutinib, such as AF and bleeding, which meant that the median time on ibrutinib was only 2 years. So a bit like having a 2-year maintenance. And they got a lot of infections as well. But still, it's interesting that it improved progression-free survival. And then the other one was the Enrich study, which is the UK-based study from Plymouth. So that was a phase 2 randomized controlled trial. Again, this was only open to those over the age of 60 with mantle cell lymphoma, and they would either get randomized to ibrutinib, so rituximab and ibrutinib, where you have rituximab monthly for 6 months, followed by rituximab maintenance for 2 years with continuous ibrutinib therapy, or traditional chemotherapy, so R-CHOP or R-bendamustine, followed by R maintenance. So either chemo versus chemo-free arm. And so that's the other study that's going on in mantle cell lymphoma, looking at using your Bruton tyrosine kinase inhibitors more. And then you've got the Mangrove study, which is comparing R-bendamustine with zanubrutinib rituximab in the autologous stem cell transplant unfit mantle cell patient as well, which will also be interesting to see the results of that. So watch this space, basically. I think BTKIs are going to creep up the sort of treatment sequence to become more frontline, particularly.
I was going to say, it feels like that must be the way forwards, considering if the average age or the mean presentation age is 68 and, all of our sort of people are not getting allos because they're already too old and comorbid, it feels like there needs to be someone to fill that niche.
Exactly. Fine. So that's first line treatment of mantle cell lymphoma, both for your fit patients, which is currently intensive induction auto maintenance, and your non-fit patients, in which your treatment is currently R chemo of some kind, R bendamustine usually. And then what about if that patient then relapses? Because we know that the progression-free survival isn't great, so they're likely to relapse. Let's say they've had an autologous stem cell transplant and we're dealing with our fit patient, therefore. What next? What could you give them as second-line therapy? What would you do?
So is this a time for BTK inhibitors again?
Yes, exactly. So this is where currently we're allowed to use BTKIs. But before we do that, we need to firstly rebiopsy the patient, okay?
Yep.
We should do the TP53 mutation assessment again. And on the biopsy, we want to look at that Ki67 percentage, because what we want to do when somebody relapses is get an idea of the risk of their disease, because it might have changed. They might have started as a low MIPI and now actually they've got high risk disease. And the reason why that's really important is because it allows us to then plug it into this new scoring system called, very catchily, the 2L BTKI MIPI, which stands for second line BTKI MIPI score, which is basically a score that you can do. You plug in the different things to allow you to identify those that are least likely to have a good outcome with a second line BTKI, so that you can grab those patients out, identify them early, follow them up really closely on ibrutinib second line therapy, and get them to something like a cellular therapy or a trial early, basically. So something like picking them up and referring them for CAR T, for example, early. Does that make sense?
Yes.
So it's a model that uses time to progression of disease, Ki67 percentage, and MIPI score at diagnosis originally, and it divides them into 3 groups based on a 2-year progression-free survival. So low risk disease having a 64% progression-free survival, and high risk disease being a 14% progression-free survival at 2 years. And those are the ones that you really want to get into a clinical trial or a cellular therapy early on. And also the BSH mantle cell lymphoma guidelines actually recommend discussing those patients with a CAR T center at first relapse. So at this point, if you then calculate a 2L BTKI MIPI of which comes up as a high risk disease, you should be discussing those patients with a CAR T center, even though they're not going to be eligible for it yet, so that they're primed and ready and waiting for their referral if they don't respond in the way that you want them to when you start them on ibrutinib, okay? Because there's a big push to get patients that are not going to respond to ibrutinib to CAR T as soon as possible, because we know that the big problem is not how effective CAR T is third line, but getting them to CAR T third line. That's the challenge, is holding the disease enough to get them there. Does that make sense?
Yeah.
Cool.
I guess if you've only got a 14% chance, then you know you're going to see them within the next 2 years.
Exactly. And so the less of a delay, the better.
Yeah.
Okay. So, but then, yes, your patients that have not had a BTKI in the past, so they've had, like our patient, intensive, induction, an auto, and then maintenance, and then relapsed, you're going to start them on a covalent Bruton tyrosine kinase inhibitor. So ibrutinib, which is your first generation one, which has been removed from the US but is still being used in the UK. Acalabrutinib, which is second generation, or zanubrutinib, which is also second generation. So that's your covalent ones. And these have all led to improved outcomes, particularly in elderly patients. A third do not respond to BTKIs, and they have a very poor prognosis. But overall, in a phase 2 study of multiply relapsed patients with mantle cell, the overall response rate with ibrutinib was 68%, with a CR of 20%, 21%, and that was published by Wang et al. In 2013. And a pooled trial analysis showed that actually your median progression-free survival was improved if you receive ibrutinib at first relapse compared to later relapses. So that supported the evidence. That was the supporting evidence to bring ibrutinib forwards to second-line treatment. And both acalabrutinib and zanubrutinib have both achieved an overall response rate of about 80% and a CR rate of about 40%. There's not currently any studies that look at the different BTKIs in relapse refractory mantle cell lymphoma to know which is most effective. And at the moment, the only one that we can get on the NHS is ibrutinib. But you might be able to get access to acalabrutinib or zanubrutinib via a trial or an early access scheme. And certainly the second generation BTKIs have much better toxicity profile, as we were talking about earlier. So less in the way of AF, hypertension, and bleeding in particular, which are the big side effects of ibrutinib that you need to watch out for. So that's what you would do. And for those patients that are identified as high risk of not responding, based on the 2L BTKI MIPI score, you should be seeing those patients in clinic 4 weekly face-to-face, okay, to see if they are responding to treatment. If you should obviously have discussed them with the CAR T center as we had already discussed, but also if they had constitutional symptoms like B symptoms at relapse, which are ongoing at sort of the 8-week mark, or if you also get a PET scan super early compared to what you would normally do. You would get a PET scan at 8 to 12 weeks. And if they have not got at least a partial response on that PET scan at 8 to 12 weeks, then again, you're going to be referring them to CAR T. So if they've still got ongoing constitutional symptoms at 8 weeks, or if their PET scan doesn't show at least a PR, then you're going to be referring them on to CAR-T. Does that make sense?
Yes.
And when you refer them for CAR-T, please do keep them on ibrutinib at the time, because even though it might not be doing very much, it stops them getting a tumour flare, which you can get when you stop treatment, and that can make it really difficult. So that's how you would treat your relapse patients. What if they've already had a BTKI? So some patients might have had ibrutinib front line. Let's say they were in the ENRICH study, or they were in, one of those other studies, like the Mangrove study. Then this is really an evidence-free zone, and we really don't have the data for what to give in this situation. So just give some sort of R chemo that they haven't had before. So I guess R bendamustine or R back, depending on what they've already had. Okay.
In that kind of scenario, are we effectively just trying to fulfill criteria to get to CAR-T?
Yes. Yeah. The long and short of it is yes, I guess. If they're fit enough for CAR-T, then yes. Although you would think that probably most of those patients that have already had a BTKI probably were older and not fit enough for CAR-T.
I see.
Why they were entered into one of the trials, like the SHINE trial or ENRICH, which, remember, we're looking at BTKI's first line because they're a frailer patient and less fit for an auto. But I guess if you were recruited to the Triangle study, then actually you are potentially fit for CAR-T. So you would need to give them some other chemo because you'd need to give R-CHOP or R-Bender or something that they haven't already had. Okay. So what about if they relapse after that then, David? So
to the hallowed ground of CAR-T, is it now?
Yes, exactly.
We've ticked the boxes and the bureaucrats say, yes, you may now have CAR-T.
Yeah, so CAR-T...
If they are not too frail for it.
Yeah, so CAR-T, firstly, you need to be fit enough for it, okay? And secondly is that you need to be eligible for it by the NICE criteria, which from February 2021, Brexucell, which is a CD19 T-cell CAR-T, was approved by NICE for the use of relapsed refractory mantle cell lymphoma, in which you need to have had at least 2 lines of therapy, including a covalent BTKI and an anti-CD20 antibody. That's the criteria. So you've got your anti-CD20 antibody as part of your R high dose RSC that you would have had as induction and auto. And then your BTKI would be like your ibrutinib second line, and then you relapse, then you're eligible for CAR-T. Okay. And that's the whole point of doing that rescoring, rebiopsying, Ki67, TP53 mutation status on the first relapse to identify those that are at high risk of needing to be referred for CAR-T. Okay. And the evidence for CAR-T comes from the big trial called ZUMA-2. And the ZUMA-2 study was very exciting. It showed an overall response rate of 93% for patients having CAR-T with mantle cell lymphoma, and a CR, so a complete response rate of 67%, with a third of patients having an ongoing response at 35 months. So that's pretty impressive, isn't it?
Yeah, comparative to the numbers we've been bounding around earlier, exactly. That's pretty good.
Exactly. There was significant toxicity, which particularly included CRS, which is cytokine release syndrome, which was 15%, neurological events at 31%, and infection at 32%. And other things that were a bit longer term is that persistent cytopenias are quite common after CAR-T, actually. And also they require antiviral and PCP prophylaxis for at least a year after CAR-T. But everyone was very excited about the ZUMA-2 study. However, real-world data has been a little bit different in that the efficacy and safety data was similar, but when you look at the how they analyze their data, the intention to treat analysis highlights that actually the challenge is about controlling the patient's disease at the point of BTKI, so ibrutinib failure, with significant numbers of patients dropping out between approval, yes, you're eligible for CAR T, and either the point of CAR T cell harvest or CAR T cell infusion. So that's why there's this big push now to capture those that are at highest risk of needing CAR T and of failing ibrutinib, so that you can get them to CAR T as quickly as possible, because we know that holding patients is really, really tricky. I guess I should just check. Do you know what the basic process is of getting patients CAR T like Brexacel?
I have no idea the practicalities.
Okay, I mean, do you know the basics of what CAR T is? Could you explain that?
So it's a chimeric B cell receptor. Is that right? B cell, T cell receptor.
It's a
CAR T cell receptor.
It's they're T cells, so it's a chimeric antigen receptor.
And so it's effectively you are educating the cells. So you're harvesting the cells, educating them with almost a synthetic version of the T cell receptor that can downstream activate what would be required for the T cell receptor to sort of do its business, whether that's sort of cell-mediated destruction.
Yeah.
And I guess the nice part of it is you can kind of almost program it to go for the thing that it's possibly ignoring due to the cancer sort of not being obvious to your innate immune system.
Yeah, exactly, David. So essentially you're getting a patient, you need to get them into a bit of a remission first. Then you need to harvest their T cells, okay? Then you genetically engineer their T cell receptor, the CAR receptor, against CD19, which is a classical B cell marker. So that's going to attack your normal B cells and your cancer B cells. So your mantle cell. And you're using the fact that those T cells have intrinsic cytotoxic activity. So you genetically engineer them in the lab, you then grow them up, and then you give the patient some bridging therapy, which will hold their disease whilst their CAR T cells are being made up. Then you admit them and you give the patient lymphodepletion chemotherapy to sort of like make space. And then you infuse in their genetically engineered T cells, which will then go around, find disease, bind to it, and kill it. And so they don't need to be in a complete remission. Unlike an auto where you want to get a really good response before you go into an auto because you're effectively just giving more chemo, you actually almost want a bit of disease around to allow the T cells to find it and proliferate and eat it, well, destroy it. And so there's quite a lot of steps. You know, you've got your referring to CAR T, you've got your stabilization of disease, where you're trying to hold the disease and get them into a bit of a remission, harvest their T cells, bridge them with more treatment to try and hold their disease, but without reducing their performance status, keeping them fit enough. And then you've got to lymphodeplete them with more chemo as an inpatient and then give them their T cells back. So that's quite a long period of time.
You can see how the data looks slightly swayed in its favor. If at any one of those stages the patient drops out, they don't make the final data count.
Yeah, exactly. And that's the big challenge with CAR T, is how do we hold people? We try to avoid bendamustine before they've had their T cells harvested, just because it affects T cell fitness, the bendamustine.
So is there anything else on the horizon? You mentioned the non-covalent tyrosine kinase inhibitors. Is that something that can do anything?
Yeah, so these are relatively interesting new Bruton tyrosine kinase inhibitors. So the current ones that we have, so both the first and second generation ones, are covalent in their binding. So they bind irreversibly to a residue called C481 on the ATP binding pocket of the Bruton tyrosine kinase, which irreversibly inactivates it. And some patients can then develop resistance to things like ibrutinib through mutation and loss of that C481 residue. And so these new non-covalently binding Bruton tyrosine kinase inhibitors have been developed, such as pirtobrutinib, you might have heard of. And they're quite exciting. An overall response rate of greater than 50% in patients with prior covalent BTKI exposure. And a median duration of response of 22 months. So that's pretty cool. And also their toxicities seem quite limited. They have lower rates of things like atrial fibrillation, bleeding, and hypertension, mainly because I guess probably something to do with the fact that they can bind and unbind. And so there's an ongoing randomized control trial called the Brune MCL 321 trial, which is being run by Tobier in Oxford and Dr. Wang, which is comparing pirtobrutinib versus the other covalent BTKIs at first or later relapse. And so that's worth knowing because you might be able to get patients access to these non-covalent BTKIs via trials or compassionate access. Other targeted inhibitors that might be being used in the future, venetoclax, there are some trials. There was some effectiveness of venetoclax in BTKI-resistant mantle cell lymphoma patients, but it only produced a progression-free survival of about 3 to 8 months, so pretty limited, but maybe might be used earlier on in treatment sequencing, maybe combined with something else in the future.
I remember venetoclax was talking about it being more useful in ATP53 mutated scenario. Was it CLL? Is that the same here, or is that just me reaching?
It's better in the venetoclax in CLL was better for the patients that were unmutated because it's a limited duration therapy.
Okay.
And it was the ibrutinib and the ones that were continuous therapy that we thought were probably better in CLL. So it was the other way around, actually, David.
It's a nice try, though.
Nice try, sorry. There's also some bispecific antibodies on the horizon for mantle cell. So things like glofitamab, which is a phase 1, phase 2 study of heavily pre-treated patients, and that's showing an overall response rate of about 80% and a CR of 73%. And I think bispecific antibodies, for me personally, are quite exciting because they have some of the benefits of CAR T, although they're less sophisticated than CAR T, and they're less tweakable in the future because, you know, we're getting lots of different generations of CAR T cells being made where we're genetically engineering them in more than one way. But they have the real benefit of being an off-the-shelf product. So where you've got CAR T, that you've got this inherent delay of it harvesting and genetically engineering, growing up and reinfusing. With bispecific antibodies, these work by binding CD3 on your T cell and CD19 on your mantle cell and bringing them into proximity to encourage that CD3 cytotoxic T cell to then destroy the B cell. And
almost like a catalyst.
Yeah, it is. It literally is. And actually, they're quite effective. And in these very heavily pre-treated patients in early studies, and I think we're going to see them move forwards in the treatment sequence as well. So I would say watch this space with bispecific antibodies. And then lastly, I guess there's this discussion about where would you go with a young, fit patient with mantle cell who relapses after CAR T, for example. And there's really limited data for an allogenic stem cell transplant. And although you generally get quite good long-term disease control rates in terms of there being low relapse rates of the mantle cell, the benefits are negated by the non-relapse related mortality and graft versus host disease. So generally speaking, CAR T is offered over allogenic stem cell transplants. But if you've failed everything else, then an allo might be your only option.
Okay. And if we're going to, try and finish on an all-time low after everything's relapsed and refractory, mantle cell lymphoma and CNS disease.
Yeah, I mean, it's super uncommon. So it's about 1% of patients at diagnosis. about 4% of mantle cell lymphoma patients altogether. Having said that, we have somebody on the ward at the moment who's young, fit, had an auto for mantle cell, and then came to the ward with some cranial nerve palsies and has been found to have quite classical leptomeningeal disease, and a lumbar puncture CSF flow, supporting a diagnosis of CNS mantle, and many lymphocytes, with the CSF being sort of yellow when it came out, which is always a bad sign. So it does exist, is what I'm trying to say. Risk factors for CNS disease are all the same risk factors that predict poor disease in terms of a high risk MIPI at the beginning. So high Ki67, blastoid histology, raised LDH, high MIPI. These are your risk factors for having CNS disease. So it's important that you do ask about those symptoms at presentation, but you wouldn't do an MRI and LP routinely. And both high dose cytarabine and your BTKIs, like your ibrutinib, do cross the blood-brain barrier. But it's a poorly studied area of mantle cell, because often it's the exclusion criteria in trials. It's like, do you have CNS disease? Yes. Okay, well, you're excluded from the trial, which means that there's a real paucity of evidence. So we've started this gentleman, for example, on ibrutinib as second-line therapy, because that's already second-line therapy, and we know that it crosses the blood-brain barrier. And there's a debate as to whether we should be doing intrathecals as well, given how much disease he has in the leptomeninges, bearing in mind the fact that ibrutinib has this antiplatelet side effect. And so you're not going to want to hold the ibrutinib for each lumbar puncture, but you at least need to discuss that bleeding risk with the patient for doing ongoing intrathecals until the CSF is clear. So I think that's interesting. And yeah, again, another area of mantle cell which is in need of more research, which is why mantle cell is still a very interesting topic. Certainly, I find it is.
I think you've sold me on it. Well done.
Good.
Okay. Can you sum it up for us?
Yeah.
Your three key points, the golden takeaway nuggets.
Okay. So, firstly, mantle cell lymphoma is generally bad news, except if you've got non-nodal mantle cell lymphoma, where your SOX11 negative. It's characteristically 11-14 translocation and cyclin D1 upregulation, and often people present with lots of extranodal disease, in which you need to do both a PET scan and a bone marrow for everybody for staging, plus or minus an OGD if you think that they've either got stage 1 disease and you're considering radical radiotherapy, or if they've got GI bleeding symptoms, for example. Number 2, if they're fit, then standard treatment is something based around cytarabine and rituximab, followed by an autologous stem cell transplant, followed by maintenance rituximab, which actually has an effect on overall survival, not just progression-free survival in mantle cell. And then number 3 would be, second line at the moment is your Bruton tyrosine kinase inhibitors, such as ibrutinib, but these are likely to move forwards in the treatment algorithm, particularly for your frailer patients, with the work of trials such as Enrich and Shine and Triangle, which is making us think that maybe ibrutinib up front can replace the need for an autologous stem cell transplant. And then CAR-T is your third line treatment at the moment for mantle cell lymphoma in patients that are fit. And it's really important that you think about that early and that you refer early, and you're doing a response assessment when they're on ibrutinib at 8 to 12 weeks, and that you're using your 2L BTKI MIPI score at first relapse to identify those that are at high risk of not responding to ibrutinib. And that it's a very interesting topic, and that there are lots of areas where we need to improve treatment of and understanding of mantle cell, because we are still looking at overall survival in years, and it is therefore a life-limiting illness, and can affect younger patients as well as older ones.
Grand.
Okay.
Thanks very much.
Great. All right. Well, thanks very much, David, and I'll see you next time.
Will do. Take care.
Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.